Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in any of your questions at any time, but note that we will reserve all questions until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Pituitary Centers of Excellence, is being presented by Dr. Nelson Oyesiku. Dr. Oyesiku is currently Professor of Neurological Surgery and Professor of Medicine Endocrinology at Emory University. He occupies the Lerner Chair in Neurosurgery and is Vice Chairman, Department of Neurological Surgery, and Director of the Neurosurgical Residency Program. His clinical and research focus is the surgical treatment and molecular biology of pituitary tumors. Dr. Oyesiku's laboratory has identified unique aspects of pituitary adenoma gene expression and has developed a new modality for imaging and targeted therapy of pituitary tumors. Dr. Oyesiku currently investigating the pathogenesis of pituitary adenomas using genome-wide association studies and whole genome sequencing methods. His laboratory is one of the largest pituitary tumor banks linked to a clinical database to study natural history, treatment outcomes, and molecular correlations. Dr. Oyesiku is co-director of the Emory Pituitary Center and has one of the most active and busiest neurosurgical practices in the country devoted to pituitary surgery and pituitary medicine. Dr. Oyesiku is a pioneer in the use of 3D endoscopic pituitary surgery. He was recently awarded the Gentle Giant Award by the Pituitary Network Association for his services to pituitary surgery and medicine and patients. Dr. Oyesiku has served Emory University, Emory Clinic, and the Emory Hospital on various committees. He has been selected by his peers as one of the best doctors in America and was selected by the Consumer Research Council of America as one of America's top surgeons. He is named in Marquee Who's Who in America. He is a member of the Honor Medical Society Alpha Omega Alpha. He has been visiting professor at several departments of neurosurgery in the United States and abroad. And Dr. Oyesiku has also been a longtime advisor and supporter of the PNA. We appreciate your involvement in our webinar program and to help educate patients. There will be a brief delay as we change presenters. You should see on your end to accept.
Can you see my screen, Tammy?
Yes, I can.
Wonderful. Thank you very much, and good afternoon, everyone.
Thank you.
It is indeed a pleasure to be joining you on the webinar on a topic that's very near and dear to me. What I thought I would do is to discuss the concept of pituitary centers of excellence, and hopefully this will provide insights for patients, their families, and as well referring physicians who are not directly involved in the specialty. I have my mouse and I will be pointing to certain aspects as we go along. So by way of an overview, what we will discuss is a brief understanding for anybody who is new to the topic of pituitary tumors in general, and describing the optimal management from an overview aspect. Obviously, we won't go into details on each specific topic since the time is defined, and explore this concept of multidisciplinary approach. And if you look in the top right-hand area here, you'll see what is meant by multidisciplinary approach. Fundamentally, that basically means that there's more than one specialty physician involved in the care of patients with pituitary tumors or pituitary medical issues. And that can extend from the neuroradiologist who makes the diagnosis on an MRI scan of a pituitary tumor to a neuro-ophthalmologist, a specialized physicians who can detect sudden or maybe even gradual changes in vision, an endocrinologist, and be mindful that endocrinologists are also divided into subspecialties. There are general endocrinologists, there are those who specialize in thyroid medicine, and of course there are pituitary or neuroendocrinologists. Within the specialty of neurosurgery, there are a variety of subspecialty areas, including, of course, pituitary surgery. ENT physicians also are part of the multidisciplinary team. Typically, they are rhinologists or skull-based subspecialists that assist and are participants in the surgical treatment of pituitary tumors. Radiation oncologists are the branch that look after treatment of tumors using focused beam radiation, such as, for example, gamma knife or a linear accelerator and so forth. Neuropathologists are exceedingly important in making the diagnosis of these tumors at biopsy in the surgical procedure or after the surgical procedure is done. And of course, a very, very, very important part of all of this is patient education. The best partner for a physician is an educated patient. And of course, the patient needs support of their families and other caregivers. So one question that we've got to put aside before we go too far is just where is this pituitary gland? And I prepared three views of this. And on the right-hand side is looking at one's skull, inside one's skull, from a side view. And this box is highlighting the area where the pituitary gland sits. As you can see, it's at the base of the brain. This is the brain up here. And the lesion or the tumor typically resides in the pituitary gland, which is sitting at the base of the skull. And you can see, relative to the eyes, nose, and mouth, where it resides. And this little picture that's spinning has a red blob that's sitting right at where the pituitary gland sits, and you can see behind it is the brainstem, and it is sitting right behind the nasal compartment. It's about 9 centimeters, or roughly speaking, just a little over 4 inches behind the tip of the nose. And this is a cross-section of where the gland sits, and you can see it's this little pea-shaped or kidney-shaped organ sitting below these nerves to the eye, called the optic nerves, and surrounded by this red area here called the carotid arteries, which supply the brain with blood. And right around the red material, the artery, is the blue, which is the sinus, which carries blood away from the pituitary and the base of the brain. And then in the wall of the sinus are these little yellow spots you see right here. These are all nerves that supply the eye, or the eyes, and the face with sensation. So this pituitary gland, if you will, sits at a very important crossroads of the brain. This is very important and has huge implications for the surgical treatment of these tumors and the potential risks of surgery, as you might expect. Now that we know where it is, what does it do? Well, fundamentally, the pituitary gland is a hormone factory. It consists of 2 parts, one called the anterior and the other called the posterior. And these two parts of the pituitary are merged or fused together and are in turn connected to the brain by what's called a stalk, or pituitary stalk to be specific, which attaches the gland to the brain. And nerves come from the brain through the stalk all the way down to the posterior and anterior pituitary to control the pituitary function. So the gland cannot work without the stalk, because the stalk gives it life, gives it blood supply, and gives it instructions as to what to do. And we did say it was a hormone factory. So what kind of hormones are made in the pituitary? Well, in the anterior pituitary, which is in this figure in yellow, you have 1, 2, 3, 4, 5, 6, 7 hormones that come out of the anterior pituitary. One controls the function of the thyroid, gland, which then makes thyroid hormone. Another controls the adrenal, which makes ACTH, which causes the release of another hormone called cortisol from the adrenal cortex. And then FSH and LH, which control the gonads to produce the sex-controlling hormones. And then growth hormone, which is responsible for growth and metabolism across the entire body. Prolactin is very important in breast milk production, and the endorphins control or released into pain receptors in the brain. In the back part of the gland, called the posterior lobe, here in green, right here, also connected to the brain by a stalk, it releases two hormones, one called oxytocin and the other called ADH, or antidiuretic hormone, which controls the kidneys and controls water balance and electrolytes. Oxytocin is required for the uterine muscles and the breast milk production. So let's go through just real quick the functions of the gland. Very important, in fact crucial, essential for normal growth and sexual development. Without the gland functioning properly, these things cannot occur. Fertility, normal blood pressure, normal glucose function, and normal body temperature. Again, very, very important requirements. The normal response to stress and the response to acute illness, also under the pituitary gland control. The normal metabolism or the regulation of the bodily functions that we all take for granted and we just assume will happen naturally is under direct control of the pituitary. Lactation, the production of breast milk for feeding the infant, is also under control of the pituitary gland. And then water balance and electrolyte balance, things like sodium and potassium, also under control of the gland. So this is a partial list of symptoms, if you will, because we couldn't go into all the symptoms. It would take at least 2 or 3 more slides of things that may be experienced by a patient who is having problems with pituitary function. Again, recall that this is not an exhaustive list. Fatigue, weakness, weight gain, weight loss, either one, you can be as a result of pituitary dysfunction. Changes in appetite, skin changes, acne, for example, stretch marks in Cushing's, skin tags in acromegaly, infertility, as we saw in the previous slide, irregularity of the menstrual cycles, sexual problems of any kind, decreased libido, for example, interruption in visual function, either frank loss of vision or blurring of vision, changes in bodily appearance, teeth, nose, hands, feet, breast milk discharge, changes in body temperature control, feeling too hot, feeling too cold, changes in mood, sadness, elation, problems with sleep, changes in memory or attention or focus, high blood pressure, low blood pressure, diabetes mellitus, and another form of diabetes called diabetes insipidus, which is as a result of impairment in water balance. So let's go to the patient who has just been told they need surgery for a pituitary tumor, or they may be told they need brain surgery to remove a pituitary tumor. Either one is scary. So what does it really mean? Well, first the good news. The good news is that virtually all of these tumors are benign. Now that doesn't mean all of them are benign, but it means most of them, the overwhelming majority. Probably less than 1 or 2% are truly malignant, either tumors that came from somewhere else. So that's the good news, which basically means these are not usually cancers. There are 2 fundamental types of these tumors. They may be called secretory or non-secretory. Some people call them functional or non-functional. And basically that is used, it's a term, if you will, used to describe whether or not there is an associated overproduction of pituitary hormones. Recall that there is several types of hormones that the pituitary produces, and any one of these hormones can be overproduced by a secretory pituitary tumor. In fact, sometimes you have two hormones that are produced or overproduced by pituitary hormone. The non-secretory ones usually do not overproduce pituitary hormones, and in fact may be associated with a decreased production of pituitary hormones. The tumor may be large or may be small. Usually we have a dichotomy. We say a tumor that's below a centimeter in diameter. So that's just less than half an inch. A half an inch is about 12 millimeters. Half an inch is called a microadenoma, and one that is above or bigger than a centimeter is a macroadenoma. And the dichotomy is actually important because it has to do with the size of the tumor and the kind of symptoms it may cause, and it also has to do with the growth rate. In other words, if nothing is done over a time period, microadenomas, in other words, those below a centimeter, tend to grow less rapidly than macroadenomas, which may be 2 centimeters or something at the time that they are diagnosed. And increasingly, because of the ubiquity of MRIs, we are now finding these tumors incidentally meaning the patient underwent an MRI imaging study for some other unrelated reason. For example, they were in a car accident, bumped their head. They were getting an MRI because they had problems with their spine, and because the MRI looks at the base of the brain as well, one finds these tumors, or they're undergoing screening for some other reason entirely unrelated to the pituitary. And approximately somewhere between 16 to 18% of people are believed to harbor a pituitary tumor. Now, not all of those patients or people that have a pituitary adenoma on MRI screening need an operation. But the fact is that it's more common than we previously thought. Some tumors come to attention because of problems with vision, and of course surgery to remove those tumors can restore vision as a result of taking it out. Sometimes the tumor is a microadenoma, but because it's producing hormones in excess, surgery or medical treatment is needed, because in the absence of treatment, these can cause devastating medical problems or even shorten one's overall lifespan. So very important to understand the rationale for treating it, and if you have been told you require surgery, these are the kinds of questions and issues that should cross one's mind as you weigh the need and the indication for removing the tumor. Now, how is the surgery performed? Most pituitary tumors, in fact, the overwhelming majority, can be removed through an operation through the nose, called an and hence the name, endonasal or intranasal operation, and through the nose leading into this chamber right here, called the sinus, the sphenoid sinus, which is filled with air. It's part of the bones of the base of the skull filled with air, and this chamber leads the surgeon into this chamber called the sella turcica, or the Turkish saddle, where the pituitary gland resides, right here. And recall that it is surrounded by the carotid arteries, the nerves that go to control the movements of the eye and sensation to the face, and above the pituitary are the optic nerves, the nerves that go to the eye. So again, the overwhelming majority can be treated, managed surgically through this approach, going from here through the tip of the nose into the nasal cavity, along this structure here called the septum, into this structure here called the sphenoid sinus, and then voila, you're looking at the pituitary fossa or the sella turcica. Occasionally, rarely, a craniotomy is required. A craniotomy means an opening in the skull. Why would this be required? Very, very large tumors that are in the brain compartment that are very difficult to reach through the transsphenoidal endonasal approach may be candidates for a craniotomy. There are a number of ways, and I don't want to get overly technical, but there are a number of ways to decide which approach is required for which patient and which condition. A lot depends on the nasal anatomy, the size of the tumor, how big it is, what the configuration it is, in other words, which areas does it occupy, the goals of surgery, what are we trying to accomplish? Are you trying to remove all the tumor, part of the tumor? Is it a functional tumor, or is it a non-functioning tumor? Are we operating for vision loss, or are you operating for hormonal function restoration? And the type of tumor, if that's known a priori. Some patients require reoperation, and that has to be taken into consideration in terms of what's been proposed and the risk involved. And then if there was prior surgery, if this is a reoperation, where was it done, when was it done, how was it done, precisely what was done. And these considerations needs to be deliberated very, very, very carefully with the patient, their caregiver, the referring physician, the neurosurgeon, and so forth. And of course, the endocrinologist is an integral part of that decision-making tree. Now, this little montage here says, can we see what's going on in the operating room? You might imagine that going through that passage that I showed you through the nose, it would be difficult to see because it is a very narrow passage and it's dark, and it's very difficult to see there without lighting and magnification. There are a number of ways that the operation can be performed. In this day and age, there's an increasing emphasis and focus because of the technological improvements that we've been able to bring to bear on endoscopic surgery. So you may see or hear or have come to understand the role of endoscopy, or maybe it's been considered in your operation, and the reason why is because of these technological improvements. Prior to this, and still in many centers, is the use of this tool here called a microscope, and this microscope also allows the surgeon to see deep inside the nasal passages and to remove these tumors through that approach. This, in this corner, the bottom left corner, is a different kind of endoscope which we use here called a 3D endoscope, which allows visualization deep inside the nares, again using this tool here called an endoscope, but allowing the surgeon to see in three-dimensionality. In this bottom right-hand corner is the typical position where the patient is positioned on the operating table, lying flat with the head cocked slightly backwards and with the nose facing the surgeon who's standing right about here. This right here is the typical appearance of a before picture. Now you see it of a tumor, and this is an after picture of the tumor following successful resection or removal by transsphenoidal surgery. There are a myriad of instrumentations that is used in the course of this operation, and this is just a small sampling of an instrument tray, and you can see many of these are fine instruments, the endoscope up here, various forceps and so forth, rongeurs to remove bone, bipolar cauterization to control bleeding, different types of curettes to remove tumors, different types of suctions of various length, and so forth and so on. So a very extraordinarily specialized set of instruments to remove these tumors. Some key points. Like everything else in life, surgery is no different. The success of a surgical procedure is critically dependent on the skill, the volume of the experience of the surgeon in performing these operations. This is a specialized operating procedure like any other specialized operative procedure. And in general, as you might expect, all things being equal, the most skilled and experienced surgeons generally have the highest rates of cure, and the rate of complications in general is lowest amongst the most skilled and experienced pituitary surgeons. And as you might expect, most of these surgeons operate or practice at major pituitary centers who specialize in these cases and operate on patients with these types of problems every day of the week. So the key mission of a pituitary center of excellence, which is the core of this discussion this afternoon. There are three key missions that are in this portfolio. One, and most important, is to provide a comprehensive state-of-the-art care and support to patients with pituitary disorders. It doesn't matter if it's a medical disorder, it doesn't matter if it's a surgical disorder, it doesn't matter if it's both, it doesn't matter if it's related to vision or an ENT problem that's related to pituitary surgery. The comprehensive state-of-the-art care is key. In other words, one-stop shopping where you can get all of it attended to by a bevy of specialists and subspecialists whose dedicated focus is on the management and treatment and research and training into pituitary problems. And they all share the common goal of making sure, within the limits of human endeavor obviously, exemplary outcomes, top quality, safety, and patient satisfaction metrics, which is all to benefit patients and elevate standards. Now, the concept of a center of excellence in healthcare is not new. It has been around since 1991 when it was first associated with the Centers for Medicare and Medicaid Services, CMS, in heart bypass surgery. And basically the concept is a cohesive team of specialists who promote collaboration, apply the best practices around a specific focus. In other words, they're dedicated to a specific thing or disease disorder to improve results and overall outcomes. There are several other examples of centers of excellence. One notable example is that in women's health, which was established in 1996 by the United States Department of Health and Human Services. And over that next decade, virtually 20 centers were designated and met the criteria. There are others that are notable that could be mentioned. One is in bariatric surgery. Another is in trauma centers. Trauma centers have been designated by the American College of Surgeons, which was established way back in the 70s, providing guidelines for the operation and verification of trauma centers. Stroke centers are also very important, a similar concept, in other words, to have stroke care, again, focused in on a very, at a very high level at specific centers. So same rationale, again, that has been applied to various fields of medicine is now being applied to this concept of pituitary centers of excellence. And it's very important that this, this concept be held in mind when patients, their caregivers, referring physicians have patients with this particular problem. And I alluded to this a little earlier on, the high prevalence or the increasingly high prevalence and impact of pituitary tumors warrants this concept of centers of excellence, because the complexity of the diagnosis, the complexity of management of these tumors and these patients is extraordinarily important to raise awareness in the medical community and improve understanding. And the only way this can be done is to have a dedicated focus of attention and care at these types of centers of excellence. So the rationale, again, just to go through, the field is fast moving. There's advances taking place in endoscopic surgery, advances in radiosurgery, in medical endocrinology, in imaging, and in pathology. And it is absolutely impossible for any one place to participate in these advances if they do not focus or train attention to this particular problem, because they'll be left behind in terms of the field. So having a dedicated focus is extraordinarily important. Improving outcomes and extending the experience, again, can only be done where people have the volume and the commitment and the dedication to doing so. So the mission, just to break it down into three components. Component number one, which is the most important, is the patient, providing superior patient care. And in order to do so, such a center must have a dedicated leadership, medical director or co-directors. One should look for a sufficient track record in surgical experience, patient visits, and volume of material to be able to develop such experience. An experienced endocrinologist, an experienced neurosurgeon, both with track records in pituitary medicine and surgery, are exceedingly important. One should look for an environment in which there is multidisciplinary collaboration between the neurosurgeons, the endocrinologists, ear, nose, and throat, neuroophthalmology, radiation oncology, neuroanesthesia, and neuropathology. It's also very important for these centers to document their data collection and the caseload, because it's only by measuring results that results can be improved. If you don't know what the results are, how will you know whether they're better or worse than they were yesterday or last year? Instrumentation and equipment is expensive and therefore needs to be purchased, taken care of, and new equipment needs to be brought to bear if and when necessary to refresh and improve upon what's available. It's very important also to have allied health professionals, nursing staff who will care for the patients, nursing program coordinators, social workers, patient support groups, and education for patients and their families. And these need to be all part of the concept and provision of services of a dedicated center of excellence. Typically, these centers will also provide training for medical staff, whether they be residents or fellows or nursing or continuing medical education for other surgeons. And last but not the least, they'll be engaged in the advancement of the field through research themselves. Clinical trials, for example, new studies in molecular biology or tumor biology or imaging, quality of life studies, and outcomes research. Now, the question always arises, who should be in charge of designating these such things? Of course, that's an open question. I've given you examples of how in some areas the American College of Surgeons has been important, or the Centers for Medicare and Medicaid has been important. Any of these types of bodies and organizations are certainly able to do this. And of course, there are many societies dedicated to pituitary surgery or endocrine medicine that could also participate in doing so. In conclusion, there's an abundance of data now that the optimal management of pituitary patients, whether it's their medical management or their surgical management or their ophthalmological management or their total well-being, needs and requires a coordinated multidisciplinary approach by experienced specialists. and creating an objective recognition process obviously is going to help this goal. And it's absolutely important that patients, their families, and referring physicians need to understand this concept as they direct their patients and counsel their patients and seek for their patients the best care of their particular conditions in pituitary disorders. And with that, I will thank you for your attention and time, and I'll be happy to entertain any questions you might have.
Thank you, Dr. Oyesiku. That was an excellent presentation. I do have a few questions. The first one, 60-year-old woman, hypopit for 30 years now. After much deliberating, was put on growth hormone about 14 years ago and still cannot seem to gain any muscle tone. I feel like I keep wasting away. Any suggestions? Thank you in advance.
Well, that's a very interesting question. Obviously, if it has been determined that there's growth hormone deficiency, which it sounds like, and the replacement treatment is being given, then one has to question why there isn't an improvement in the overall condition. And this may be the question that needs to be answered, is why in the face of therapy is there no improvement? And I assume that the other criteria for growth hormone replacement have been met, and it's only the muscle condition that is at play. So if that's the case, and it's the growth hormone treatment is otherwise working except for this particular area, then the first question that would come to my mind would be, is there some other reason for muscle deconditioning or muscle wasting or muscle loss? And that question may need to be answered first if in fact we know that growth hormone is being replaced adequately and so on. And obviously this would be a good question to have looked at by a neuroendocrinologist at a pituitary center.
Thank you. Next question. I'm a 56-year-old male who had a pituitary adenoma, prolactin tumor removed in 2012. Prolactin level was 3,000. Now it is down to 40. Most of the pituitary and the tumor was removed. I am taking 30 milligrams daily of Cortef for my adrenals, along with 100 micrograms of Levoxyl. I get very fatigued daily. Questions. If a new patient comes to your center after having pituitary surgery, what type of workup would be done? Is there a way to test the adrenal level even though I am on Cortef?
Yes, of course. There are definitely ways to test adrenal function, even if you were put on hydrocortisone. And obviously, what you want to know, or at least one of the things we would want to know, is what your functioning is absent Cortef replacement. In other words, where's your baseline endogenously? What do your glands themselves produce? Number one. And then do you have any reserve at all? And there are ways to test that as well. And then based on those two things, your baseline and any evidence of cortisol reserve in your body, then come up with a treatment dosing regimen. And they're usually guidelines for where to start. And if it is insufficient at the starting level or dose or frequency, that can be increased to fit sometimes lifestyle and demands of the individual patients. And sometimes that needs to be titrated up during times of stress or illness and so forth. And so the short answer is yes, you can test for adequate adrenal function, and yes, you can have adjustments made to fit your particular lifestyle or your particular needs so that you're not constantly feeling under the weather, if you will.
Thank you. Okay, I read there is great success in using stem cells to function as a pituitary. Is there any pituitary stem cell list I can get on to guinea pig for this procedure?
Stem cell research is very promising, no question about it, and not just in pituitary medicine for replacement obviously the ultimate goal would be replacement, but it's still early days now to enter into direct treatment by stem cell, whether it's transplants or grafting or what have you. There's been success in the laboratory with stem cells, and we do know that they do produce these hormones. So I would venture to say, that whilst we're not there today for widespread clinical use, but we should be there soon. But in the meantime, thank God, we have treatment options for hormonal replacement for virtually all the pituitary hormones. So stay tuned. I think it's close, but we're not there today yet.
Thank you. Why is endorphin deficiency replacement rarely discussed in the context of the treatment of pan-hypopituitarism?
Yeah, I think that's a very interesting question. I think one of the probable reasons is that there are lots of other sources for endorphins. I think that's one thing. Whereas, for example, ACTH is pretty much confined to the pituitary, except if they're other ectopic sources. So I think that's probably one of them, and I think it's probably very difficult, to know exactly just how much endorphins one needs, and so I think it's would be empirical at best, and I don't think we're at a point where that is part of the regular armamentarium of replacement therapy.
Okay, next question. How much are medical students required to learn in regards to pituitary tumors?
Well, most medical schools have a very well-crafted, comprehensive curriculum that addresses pituitary medicine. Certainly in our medical school that is the case, and that would be the case across the United States and for sure. So I doubt very, very much that there's a medical student out there that would go through a regular curriculum and not be guided by their treatment their exposure to endocrinology in medical school.
Okay, I live in an area where there are no COEs for pituitary tumors. What are my options? And then additional comment, P.S. I am not independently wealthy.
Right. So this is a very, very important question. This is a very important question from the standpoint of many things. First of all, from just purely patient convenience. Not knowing exactly where you live, but it doesn't matter. Getting from wherever it is that one lives to the destination point where one can find the specific multidisciplinary specialized care that is requires effort. It requires effort in finding out the facts, sometimes by asking questions of your primary care physician or your referring physician, because they may or may not know, because not everybody's going to be actively engaged in this if they're not a specialist. Then it takes a fair amount of inertia to get up from wherever you are to go seek this person or center. Then you've got to contend with all the problems that we have in our system with insurance coverage and so on and so forth and so forth. And then you're out of your own station. You're not right next to where your family is and so forth and so on. And this is a very, very difficult problem. But in all the years I've been doing this, at the end of the day, despite all these hurdles that sometimes have to be crossed in the final analysis, it's almost always the case that you're better off getting the best attention, even with all the extra effort it might take, to get it done once and for all and get it done right. It's always more difficult to retrace one's steps and to fix something when it could have been done differently, or it could have been done better, or you didn't even need what you got done, you needed something else, but they couldn't provide what that something else was because they didn't have it, etc., etc. And I prefer the philosophy measure twice, cut once, and I think it's extraordinarily important that despite the difficulties you may be facing to do this, it's always better to seek the best the first time around.
Absolutely. Thank you. How can people be more proactive so that their tumors are discovered sooner? I believe I had my tumor in my teen years. I was not diagnosed with my tumor until I was 48.
That is very possible. You may have had as we talked in the webinar, you may have had a microadenoma in your teens. Microadenoma could have been as small as 1 millimeter or even less. You may not even have been able to see it on an MRI, but because these tumors grow very, very slowly, it could hang around for 10 years, 15 years, and only grow so slightly. And then when it reaches a critical mass, say maybe a centimeter or a centimeter and a half, then begins to take off, and then you only discover it in your 40s. The only way of discovering these things sooner, before they become symptomatic, as you know, would be to do screening, right? Which is done for a lot of things. For example, people get screening colonoscopy after a certain age. People get screening chest x-rays. People get EKGs. Some people get mammograms and so on and so forth. But as you all know, many of these screening procedures, screening protocols are based on criteria that have been worked out based on epidemiology and so forth, and they carry a cost. So if it's not approved medical screening, then you probably will find that the insurance company probably is not going to be covering the cost of screening, and then that has to be borne by the patient themselves. So absent changes in our medical guidance and guidelines, the only way would be to get this sort of screening done would be because somebody wanted it specifically and was essentially paying out of pocket because the insurance company industry doesn't recognize that because it's not a medical guideline. And so that's the only way really to find something before it comes to attention is to have the screening tool, really.
Okay, thank you. Could the fact that I am pan-hypopituitary be the reason for my body not absorbing ferritin? Is there anything I should be aware of in having iron infusion? I am a 53-year-old female and have had the first tumor removed transperineally and the second by radiation, and had a third removed 3 years ago that was a meningioma believed to have been caused by radiation.
Yes, so I don't know. I am not an expert in iron metabolism, so I will not be able to comment specifically on the issue of ferritin and iron absorption and what you should do about it. But it is true. You mentioned that you had a meningioma and you had radiation and had a pituitary tumor. Certainly, radiation can cause hypopituitarism. That's well known. And occasionally, patients who have had radiation after an interval of maybe sometimes as much as a couple of decades or a decade and more, sometimes will develop what we call secondary tumors. I would defer the answers to your question relating to iron and iron metabolism to an expert in that field.
Okay, thank you. Is there any research being done at this time to discover the cause of these tumors? 1 in 5 seems to be very high.
Absolutely. In fact, there's a lot of research being done to look at these tumors from the standpoint of causation or contributory factors. That begins rarely with analyzing the tumors taken out of the body at surgery. In other words, having those tumors in one's possession is one of the first and most important steps, because it's only by being able to analyze those tumors that one is able to decipher some of the mechanisms that are at play. And so tumor banks have become extraordinarily important in dissecting the cause of these tumors. And a lot of major pituitary centers will have tumor banks. We certainly have one here, a very, very large repository of tumors. And so that's very important. And thanks to things like the Cancer Genome Project and the Human Genome Project, we know what the normal DNA profiles are now. We're getting a better handle on those, so we can compare abnormal gene profiles with the normal, and we can, say, for example, abnormal gene profiles from a tumor with that from a normal gland, and as a result of which we're able to detect the abnormalities in chemistry of DNA or RNA or both, and this has been able to instruct and illuminate the causation of these tumors, and there are increasing number of scientific papers now being published on this. Just in the past year, as an example, for example, in Cushing's disease, we were able to just recently, not we, but groups have been able to begin to tease apart the causation in terms of DNA changes and so forth in Cushing's, and I'm sure there'll be others. Recently, about 10 years ago, we also looked at another subset of pituitary tumors called clinically non-functional tumors. We found an abnormal receptor in these tumors that is able to, we were able to identify about 80 to 90% of these tumors. So it's stuff like this that helps us slowly but deliberately grind away at the causative factors.
Excellent, thank you. I am a 48-year-old male who was first diagnosed with Cushing's 28 years ago. In those 28 years ago. In those 28 years, I've had 3 transperineal surgeries and gamma knife with no relief from elevated ACTH levels. I finally had a bilateral adrenalectomy in 2007. I have MRI studies done annually with no detection of tumors in those studies. My question is, are there new imaging technologies that could possibly find or reveal the tumors?
Yeah, now there is I assume you may, right, let me say, there's a possibility, I mean, as based on what you said, that you probably had things such as IPSS, which probably would have been done to try and see if they could detect the tumor in the pituitary gland. There are some centers that do another imaging study called a PET, which is called positron emission tomography, that sometimes is able to detect areas of protein synthesis in the pituitary gland that is may reveal some hidden tumors sometimes, and sometimes these tumors are so small they're almost impossible to detect. And it sounds like in this particular case that may have been part of this or not. I'm not. It's hard to tell. But those are the other than MRI scans, those are the some examples of tools that are used to try and figure out maybe where the tumor may lie.
Okay, do they think these tumors are a mutation caused at conception that develops into a tumor later in life?
Rarely. There are such things as congenital tumors, in other words, tumors that occur soon or shortly after conception. that are due to mutations at a very, very early stage of development, and of course then pop out very early in life. But it's very, very unlikely that these types of tumors that we've been discussing, at least pituitary adenomas, develop that far back. I'm not saying they don't, but I'm just saying that it's unlikely. Typically, those types of tumors that develop very early on would present, much earlier. So it's unlikely that these are the kinds that present that early.
Okay. Since I had most of my pituitary taken out in 2012, is there a way to test how much pituitary function remains? I do get an MRI each year. The doctor is unsure if the image on the MRI is part of the remaining tumor or where the tumor was bleeding inside the pituitary gland.
Right. It's fairly straightforward to determine whether or not the pituitary is functioning, even without an MRI. And the way to do that is going back to, if you think back to some of our earlier slides in the webinar where we discussed the hormonal production of the gland and so forth. So the gland basically is a hormone factory. So if you measure those hormones, you can detect whether they're being produced, whether they're being produced in sufficient amount or not. And the endocrinologist can also do tests that are called tests of stimulation. In other words, you give something, another chemical, if you will, to query whether the gland is able to respond to that stimulus. And that's another way of testing whether or not there is residual function in the gland. And that's, again, done by biochemical test, not an MRI scan. So the best way of really telling if you have functioning gland tissue is to actually measure the functioning of the gland. And by doing so, that question can be answered with a higher degree of reliability than just merely looking at whether or not you see tissue within the pituitary area on MRI.
Okay, thank you. If a person has had idiopathic hyperprolactinemia for 5+ years and has been treated with both cabergoline and bromocriptine intermittently, but still continues to have a raised prolactin level a few months after medication is stopped, what other labs, test options to suppress the excess prolactin are available? At one time, pituitary MRI showed small adenoma. A second pituitary MRI years later showed no adenoma. What's next? How often should a pituitary MRI be repeated? Is there a better MRI machine to check this, or should they always be with and without contrast?
Yeah, so the last part of your question, are there MRI scans that are available that could detect these tumors other than with and without contrast? And the short answer is yes. There's some other sequences that can be done to look for tumors that are not just straightforward with and without contrast. They're dynamic imaging studies. They're those that are done with different strengths of MRI scans and so forth. So the best thing really is to get that done through your pituitary center, and it sounds like if there was an MRI at one point that showed and another MRI at another point, it could be either as a result of treatment of with the medicine that caused the tumor to regress, and maybe that's why it disappeared, and under treatment, that's one of the potential possibilities. In terms of prolactin elevation, the causes of prolactin elevation are legion. They're really a long laundry list of potential causes that may not be tumor related, and so having it's almost like going through a detective analysis and trying to rule this in or rule that out or something. And this is something that you and your endocrinologist need to sit down and look at. Medications, for example, that have been used in the past may play into this. There's various medications used for various other things that can cause elevations in prolactin. Not every patient that is treated with medical therapy responds to medical therapy. Most do, and sometimes they don't, because the medical therapy is predicated on the receptor activities in a tumor and so forth. Some patients do not tolerate the medications for whatever reason, and so cannot take sufficient amount of the medication to result in normalization of prolactin levels. So I think it's extraordinarily important. This is the kind of question that requires concerted attention with an endocrinologist, going through carefully the previous medical records to determine what was given, when, etc., etc. Look at the MRI scans, make sure the quality was very good, make sure the appropriate sequences were done, and so on and so forth. But yeah, those are the steps that I would consider taking in that scenario.
Great, thank you. What is the smallest size of a macroadenoma? Microadenoma.
The smallest?
Yes.
Well, in theory, it would be somewhere between 0 and 1 millimeter. So 0.1, 0.2, 0.3, all the way to 1 millimeter. Because in theory, by anything that is 0 to 10 millimeters is a microadenoma. And unfortunately, the MRI scan has a finite resolution, and so beyond a certain size, it becomes very difficult to see these things on MRI scans, even if they're there, because the MRI can only see so much, and with only a finite degree of precision. But yeah, you could have a microadenoma that's a few microns in size, but nobody could see it because it's so small, and we don't have any means of seeing that clinically.
Okay, thank you. I heard about a study in Italy that acromegaly developing in areas where there is exposure to certain chemical pollutants. I developed acromegaly and think it might have been exposure possibly to secondhand smoke or mother smoking during pregnancy. Have there been any studies with cigarette smoking and these tumors, since cigarettes contain many chemicals that are harmful?
Right. The short answer is not that I am aware of directly, and I don't know of this particular study from Italy myself. So the short answer is I don't know. Not that smoking is ever good for you, but in this particular case, I just don't know that there's been a direct link that I'm aware of.
Okay, thank you. Other than some thank yous and great information, that I think concludes our questions.
Okay.
Make sure. Yeah, that is all the questions that we have. Excellent questions, by the way. You guys have been
excellent.
awesome. Great participation.
Very thought-provoking and very challenging and so forth. And this only underlines. I hope this only further underlines the concept of the fact that this is a very complex area of medicine. It's a complex area of surgery, and it really does require, like anything else, to be done right. You need the dedicated, focused attention of skilled, trained practitioners who live and breathe this area, and this is what this is about, and is finding the right skill set to take care of these extraordinarily complex and challenging parts of medicine and surgery. So thank you very much.
Thank you, Dr. Oyesiku. That's absolutely agree with everything you said. There is actually one more question. What is the significance of non-diabetic hypoglycemia to pituitary issues or other endocrine disorders?
Say that again. Non-diabetic?
Non-diabetic hypoglycemia to pituitary issues or other endocrine disorders. Well,
of course, if they're there are other causes of one being hypoglycemic that are not related to diabetes, and certainly being hypoglycemic for other reasons in a patient who has pituitary dysfunction can only make it much more difficult for it to be treated and more challenging for it to be treated. You can imagine if you're doing something to correct hyperglycemia from pituitary dysfunction, say diabetes from acromegalic patient or from a Cushing's patient on the one hand, and on the other hand the patient has some other cause for episodic or continued hypoglycemia, it can be extraordinarily challenging because the one would essentially work against the other. So that is absolutely a management challenge and needs to be handled again by, as I said before, say it again, one who is a neuroendocrinologist specializing in pituitary management.
Great, thank you. Again, excellent presentation, excellent questions. Thank you, everyone. Thank you, Dr. Oyesiku. This concludes today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, if you'd like to share it with family members or friends, it'll be available on our website after it is edited. The P&A wishes to thank you for participating. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you for joining us, and enjoy the rest of your day.